Okay, good morning, everyone. We're going to go ahead and get started. Before launching into our formal program this morning, Dr. McIntyre is working on an email from us that will detail all the visiting professors coming this spring. It's actually quite a busy visiting professor season. And before I forget, you actually have it up? Actually, you're on, Rob. In addition to the email, Dr. McIntyre is going to briefly go through our schedule. Before I forget, I have to thank Dr. McIntyre. He spends countless hours arranging our grand round schedule and making sure that all the visiting professors are in the right slot. And after that, Dr. Ash Gosain will introduce our speaker this morning, Dr. Fritz, who's had an incredible career here at the University of Colorado and Children's Hospital, and really has been a cornerstone of this department. So thank you.
His slides are still. So I want to wish everybody a happy holidays, because this is the last grand rounds of the fall half of the academic year. As Dr. Schulich was mentioning, we have a special grand rounds this morning with Dr. Carr. But I did want to briefly update everybody on our plans for the spring half of the academic year with our visiting professors. So to start the year out, we're going to have our first grand rounds in January is going to be, well, if I can get the slide to move forward. What's going on? Oh, it's not there. So I need to go back one.
Position.
Well, let me just go through it real quick. On January 8th, which is going to be the first grand rounds in January, because obviously we're not going to have grand rounds on New Year's Day. Dr. Vanessa Nominini is going to be here to preside over our annual medical student research symposium. She was invited by Dr. Tevis. So we'll have grand rounds in the Hensel Phelps Auditorium, not in this auditorium. And then immediately following that grand rounds will be the medical student research symposium. These are all medical students who have worked with surgical faculty on research projects, and they will be presenting their work at that time. Then in January, at the end of January, on the 22nd, Dr. Vic Babada, who's from emergency medicine, is going to be here to present a report about the progress of what is called the Combat Center. So we're going to have a joint grand rounds that day with emergency medicine. Then you see January 29th on the slide there, Sean Roddy, who was invited by Dr. Emily Malgore, is going to come and talk to us a little bit about CMS and the RUC. And then the Diversity, Equity, and Inclusion lectureship is on March the 4th. And Dr. Julie Fleischlag, a vascular surgeon who is the chief executive officer at Wake Forest, is going to be the visiting professor for that presentation. And then March 18th will be the Swan visiting professor. Christina Ferrone, who's the chair at Cedars-Sinai, will be the visiting professor. She's going to talk to us a little bit about the changing landscape in pancreatic cancer. April 8th, we're going to have another sort of special grand rounds where Kristen Holmes, who is the Vice President, Chief Scientific Officer for WHOOP, which is an activity, strain, recovery, sleep tracker, is going to come and talk a little bit about resilience. And Dr. Cohen, Mitch Cohen, will be presenting data from a large study that was conducted of trauma surgeons across the United States in partnership with the WHOOP company. April 15th, we're going to have Taylor Ripley, who's a former resident here, who's currently in Houston, is a tenured professor at Baylor, is going to come talk about his own research career and leveraging our surgical practice for translational research in science. The Pomerantz lectureship is April 22nd. Dr. Donington, who's the chief of the section of thoracic surgery at the University of Chicago, will be here as a guest of Dr. Mitchell in the cardiothoracic division. Then Shabani Patty, who is a professor at UCSF, will be the Jean and Sarah Moore lecturer this year. And then to finish out on May 20th, which is the last Monday of the academic session, Leslie Dossett, who is invited by Rob McGeed, is going to come and be the presiding scientific officer over our annual resident research forum, which will take place that day. So we have a very busy spring with visiting professors. There's going to be a lot of great sessions, and I will send out an email so everybody can save dates on their calendars for those sessions. Dr. Gosain, let me hand this over to you.
Thank you. All right, that sounds like quite a packed schedule in the spring. So it is my great pleasure to introduce Dr. Fritz Carr. I think we're in for a treat today. Dr. Carr is a native of the state of Nebraska. He attended the University of Nebraska, where he received his Bachelor's of Science degree, and then continued on to receive his Doctor of Medicine degree there in Omaha as well. He subsequently went into general surgery training at the University of Arizona in Tucson, which he completed, and he's over the years been awarded a Distinguished Alumnus Award by that institution. He then started on what many of us know is often a long and circuitous path to become a pediatric surgeon. He began by undertaking some research training here in Colorado with Dr. Lilly in pediatric surgery. He then went on to be a fellow in transplant surgery under Dr. Tom Starzl at the University of Pittsburgh, and then completed pediatric surgery training at the Children's Memorial Hospital in Chicago under Dr. Raffensperger. He was then recruited back here to Denver in 1988 by Dr. Lilly and became the second pediatric surgeon in the city. And over the subsequent decade and a half, rose through the ranks from assistant to associate to professor. He is a man of impressive character. And I think one of the things that really highlights that is that after 9/11, he joined the U.S. Army Reserves. And similarly rose to the ranks from major to lieutenant colonel to colonel. He's been deployed 7 times, including 2 tours in Iraq and 3 tours in Afghanistan, and has won or been awarded rather numerous medals and commendations for his military service. Back here in Colorado, he, as Dr. Schulich said this morning, has been a fixture in this department. He's won the Outstanding Teacher Award from the department. He's won the James E. Strain Award from the Children's Hospital, which is an award given to those that exemplify the ideals of the American Academy of Pediatrics and its advocacy for child health, which I think is quite true of Dr. Carr. More personal to me, he was the chief of the Division of Pediatric Surgery from the mid-90s through 2016, and also served as the interim surgeon in chief of the Children's Hospital during a critical period as it moved from downtown here to the Anschutz campus and really helped shepherd that transition. He has really participated and helped drive the transition from that 2-surgeon group that he was a part of in 1988 to its current state, which is really a top-tier quaternary care children's hospital that serves the western half of the United States and well beyond. And on a personal note, his leadership has really helped define our division of pediatric surgery, and I've tremendously benefited in my role over the last year from the division that he set up. And he's been one of my most trusted advisors and counselors over this last year, and hopefully moving forward. And so I'm really excited to hear his perspectives this morning on the three bears. Dr. Carr.
Wow. Thank you for that kind introduction. I got asked to do this talk several months ago by Dr. McIntyre, and as he said, I told him, you don't have much to say here. I'm going to hit on three different topics. I chose three things to talk about: biliary atresia, liver transplantation, and my Army service. But I'm really just going to hit the top of the waves in doing so, because each one of those could be a full grand rounds. So let me get started. Typical no disclosure slide. One of the things that I came upon and I believe is this quote from Alex Haley. If you ever see a turtle on a fence post, you know he didn't get there by himself. Well, clearly I didn't get here by myself. I had a lot of help, people that supported me, people that promoted me, and so on. And so I'm going to try to highlight some of those folks along the way. I'm going to start with this. What was left out of my pedigree is that I was the fourth surgeon or fourth doctor to graduate from the University of Nebraska. My great-grandfather was in the first class of the University of Nebraska Medical Center in 1903. He's there in the bottom. And then my grandfather and my dad and then me, making, I think, the most graduates from one family from that institution. But really, in some ways, I really had no choice except to go into medicine. Obviously, I did, but I chose to do that, and it made it somewhat easy to step on their shoulders. So these are our topics for today. As I said, each can be a whole lecture in itself, so I'm just going to try to hit some of the things that impressed me or that we had something to do with. And these are three people that were already identified in Dr. Gossain's introduction. C. Peter Crow was my professor at the University of Arizona that really got me started in pediatric surgery. In that era, we didn't do pediatric surgery until our fourth year of residency, and immediately decided this is what I want to do. This is pretty cool. The patients are great. The problems they are well suited for surgical correction. And when I didn't match that first time, which is another sort of theme, is if at first you don't succeed and you're passionate, keep trying. I didn't match, and Dr. Crow suggested I go work with this guy named Lilly, who was interested in biliary atresia in Colorado. I did, and then the rest sort of fell in place after that. With that boost, I was able to match in Chicago and trained with Dr. John Raffensperger at Children's Memorial. So I began to learn about biliary atresia. What is it? It's an inflammatory sclerosing obstruction of the biliary tree. We tend to think of atresia as a point fixation. This is not true of biliary atresia. If it were, all the bile ducts would get dilated in the liver, and they don't. It's relatively rare, about 1 in 12,000 live births, which only amounts to about 300 babies every year in the United States. The babies usually present with jaundice and acolic stools after initially, most of them having pigmented stools. So it seems to be a perinatal sort of process that they're not in most cases, not born with, but develops over time. And if not treated, it leads to biliary cirrhosis, portal hypertension, and eventually death. And this picture at the bottom is one of the first articles or descriptions of biliary atresia, and is actually quite accurate compared to what we see today: a cirrhotic liver, a tiny gallbladder, and just cords that represent what used to be the bile biliary tree. So the first folks to really argue or to develop an operation that succeeded was the group in Boston Children's, headed by Dr. Robert Gross, one of the giants in our practice in our area. And he found that there was a correctable type, or described a correctable type and a non-correctable type. And we know now that that's not quite true, but the correctable ones were the ones where there was still some dilated bile duct or a cyst in the hilum. They would bring a limb of jejunum up to that, and some of those, only a few, would survive. The others that they explored, they did nothing, and they expired fairly quickly. Unfortunately, the ones on the left, the correctables, were a very minority, and so there were very few patients that they could help. Others tried a variety of, in retrospect, somewhat ridiculous and fruitless operations. This is a Longmire operation that was done by amputating the left lateral segment and then trying to bring a limb of jejunum up to the cut surface and anastomose to the now open bile ducts. Of course, there weren't any open bile ducts, just tiny ductules, and this operation didn't work. This was fairly intuitive, or imaginative, I guess I should say. The Sterling operation, where he took silver tubes and kind of hammered them into the liver like a maple tree to try to tap the biliary system. He reported good success, but nobody could reproduce that. And that led Willis Potts, who was at the institution where I trained in Chicago, to say congenital atresia of the bile ducts is the darkest chapter in pediatric surgery. That was 1959. Unbeknownst to him, Dr. Kasai was developing his operation in Japan and published in 1959. However, as you can see from this photograph of the manuscript, no one could read that, and it went basically unnoticed for about 10 years. He eventually did publish it in the English literature in 1968. And because of the failures of surgeons in the past who reported good success, there was a certain amount of skepticism of his operation. And in fact, some in the US said that it was a different sort of patient, a different sort of problem, and couldn't be done. Dr. Lillian Altman in Washington then practiced this operation. Dr. Lilly, in fact, went to Sendai to watch how the operation was done, came back with that information, and armed with that knowledge, reported their success with this operation in 75. He was then recruited to Denver, where then I was introduced to him in the early mid 80s. And he had this registry of biliary atresia patients. He had canvassed over 100 institutions and gathered 900 some patients. And we reported that information, that there was a female predominance, about 0.7 to 1 male to female ratio. Most of them did have a corrective operation. There was these types of anatomy at exploration. So you can see that only about 8% have the so-called correctable type. And the remainder have obliteration of the entire biliary tree. Most had cirrhosis or at least moderate fibrosis at the time of operation. And they underwent a variety of different operations. And this might be a little small to see, but I think you can see that many, if not most, had some sort of biliary stoma. I remember being on the ward with all these little yellow babies with bags on their abdomen, collecting bile, and we'd record the bile output and the bilirubin in the bile day after day, which we'll come back to in a moment. So we reported this information and showed that in a big series for the first time, there was a pretty good amount of patients, certainly not the majority, that were improved or survived longer with the Kasai operation. And those that did not have a Kasai did not last beyond their third year. Number of prognostic factors were identified. If they had fibrosis and cirrhosis on liver biopsy, that was a bad sign. If they had the correctable anatomy, that was a good prognosis. If they developed cholangitis or varices or ascites, obviously that was going to cause their early failure. And finally, the age of operation. We found, and this was reconfirmed by a number of other studies, that if the operation was done in the younger age groups below 60 days, that they had a better survival. What other things did we learn? We learned that these Kasai modifications with stomas, and it seemed like every Japanese center developed another twist on the operation, pun intended. And none of those seemed to make any difference in large studies. There was no reduction in cholangitis, which was the biggest fear and the biggest problem, complication of the operation. And the stomas also led to a variety of complications like prolapse and varices. We similarly looked at valves. A number of people designed different valves to put in the Roux-en-Y limb. And it turns out that none of those really helped. There was no reduction in cholangitis. It seemed intuitively that it would work, but it didn't. And I would say now it's very unusual for people to put valves in the stoma, in the conduit, and or to use stomas. Overall, this is kind of what we see. About a third of the patients fail from the get-go. They don't get any better. They don't clear their jaundice. They go on to liver failure. Some are improved and get through to maybe school age or teenage years, and then develop liver failure or portal hypertensive complications. And only about a third achieve long-term success. And really only about 20% get into adulthood with their native liver. The majority, therefore, requiring transplantation, which is going to lead into my next topic. So what causes it? I'm fortunate to have worked with a number of really smart researchers, Kara Mack and Ron Sokol. We've identified that there are really two different forms of biliary atresia, a fetal or an embryonal form that comes along with a number of other anomalies, polysplenia, situs inversus, interrupted IVC, so they have a persistence of the cardinal vein system, and malrotation. We think now that some of those are genetic mutations that are involved with bile duct development. But the majority are this perinatal or acquired form that usually have pigmented stools at the get-go, and then develop jaundice and acolic stools after 2 to 4 weeks. Whether this is environmental or viral is not quite clear, but it now seems that many of those have an autoimmune type of pathology. And so all of these variety of different causes seem to end up with the same phenotype of sclerotic obliteration of the biliary ducts. This cartoon kind of shows that idea that the bile duct on the right upper becomes damaged, whether that's mechanical or toxins or viruses. Those bile ducts are then chewed up by the macrophages, delivered to the T cells, which mistakenly identifies not only the invader or the toxin, but also the bile duct cells themselves, and then progresses to result in a autoimmune type of damage to the bile ducts, the entire bile ducts. And then I just put this slide together, which is a compilation of all the patients with biliary atresia that we did over the last, what is that, about 50 years. So at this point, I want to put out a shameless plug for any resident or fellow that's interested in helping me do a follow-up long-term study. We have a lot of these records. It's going to be a chore to trace them down and see what happened in the long term to this cadre of people. So as I said, the majority of those patients with biliary atresia, unfortunately, end up having a liver transplant. And while I was here with Dr. Lilly in my fellowship, he recognized that. He and these people, I'll come back to that in a second. These are the people that sort of got me going in this direction. Charlie Putnam was my professor in Tucson. I did some research with him on liver failure and a dog model of liver injury. Of course, Dr. Starzl, I was sent to by Dr. Lilly. Came here with Dr. Kalm in 1988, and we restarted the transplant program here. And then I have to have a shout out to Dr. Wax, who really filled in, as you'll find out later, when I went on a number of deployments and filled in as the pediatric transplant surgeon. So this is the very first patient was done that had a liver transplant in the world, was a 3-year-old with biliary atresia. The donor, it turns out, was also a 3-year-old that had arrested during a brain tumor resection. They tried to resuscitate that baby for 45 minutes, and then it took them 15 more minutes to cannulate. So you can imagine that the allograft was not as pristine as the ones we get today. The perfusion was also very primitive. The patient died after about 4 hours of operating with hemorrhage. And in autopsy, most of the hepatocytes had lysed. However, it didn't deter them from continuing that work. And as you can see in this is the textbook that was put out by Dr. Starzl. And you can see that Charlie Putnam was the co-author, at the time an intern in surgery. So it's possible, even at that young age, to make a significant contribution. So just to go back to the timeline, the first transplant was done here in 1967. Dr. Starzl then moved to Pittsburgh in about 1980 or 81. Fortunately, cyclosporin came online a few years later. They also added veno-venous bypass to the procedure, and the National Organ Transplant Act was in its development, so that we were beginning to get organs that were more viable than they were previously. In 87, UW came online, replacing urocolins for preservation, and then OKT3 in 1988. Well, let me back up a second. As I said, I came here to be with Dr. Lilly. We had this stable of biliary atresia kids, half of them jaundiced and in liver failure, and it was clear that they weren't going to survive without something dramatic. And at the same moment, transplantation was sort of coming online and reporting success. And he sent me off to Pittsburgh. In retrospect, I think he knew that he needed somebody to come back and help him with this stable of little yellow kids. But it was at a time when the year before I got there, they did 50 liver transplants. The year I got there, we did 300 liver transplants. It was crazy. It was pandemonium. It was so much so that the resident staff at the University of Pittsburgh said, we're not doing this anymore. It was too much work for them. So they quit rotating on that rotation because they were just getting overwhelmed with liver transplant. Anyway, one of the things that I think we added to the practice of liver transplant was questioning the need for veno-venous bypass. At the time when we came here, every transplant probably in the country was done with veno-venous bypass to prevent the sort of obstruction of the lower half of the body and provide a route to get blood back to the heart. Dr. Stigall and myself and Dr. Kalm reported this information, and we did 110 with veno-venous by first 110 with bypass, and then the next 106 we used selectively. The vast majority were not done with veno-venous bypass. Those that were hemodynamically unstable at the outset, and we found that there were no intraoperative deaths. There were no difference in mortality. We did not find any difference in the number of transfusions or the development of renal failure. And this and other papers then began to show that this was a safe thing to do. And nowadays, I think it's relatively rare that veno-venous bypass is used. But it certainly reduced the cost and the time and the complication rate of groin and axillary abscesses. Uh-oh. I think I did something wrong. Am I going through these slides? No. Let me try this. I might need technical help. Anybody? No? Maybe I can use this one. No. I'm no longer. No. I don't know what I did. I pushed a button wrong. Oh. Well, at any rate, oh, there you go. The other, okay, thank you. I don't know what I did. The next area that we made, I think, some contributions was in biliary reconstruction. At the time I was in training, every patient got a T-tube. We put the bile duct together over a T-tube, and they came again with a bile bag for the first several weeks after their transplant. Dr. Wax reported this information from UCSF and then brought that with him when he joined our group. And we found that there was no difference in biliary complications or revisions or survival. So that now is almost a thing of the past as well. Most of the children, of course, did not have a distal bile duct, so they needed a Roux-en-Y. So that was fairly routine for all of our babies with biliary atresia. They had no distal bile duct. And then we began to think, well, maybe we don't need to use this Roux-en-Y all the time. And we began to do some of those anastomoses to the duodenum. And Dr. Campson and then Dr. Bennett and others from this institution documented those results as being a acceptable way to do the biliary anastomosis. The other thing that we found, and this slide requires a little explanation, is that the ratio of donors to recipients was skewed away from the kids. There are very few young children that die of the sort of brain death injuries that result in organ procurement, so that there were twice as many babies that needed transplant as there were baby donors. And there was no way to get around that without some of the techniques that I'll show you in the next slides. It began with the use of reduced size grafts by Bismuth in a French surgeon in 1984. He showed that we could use a section or a portion of the adult-sized liver and successfully engraft that. The next iteration of that technology was to use both sections of the liver, and we did a fair number of those. And then, of course, was the development of living-related grafts, which came along with Dr. Brolsch, a German surgeon that was working in Chicago, that took a live left lateral segment from an adult or usually a parent. And subsequent paper, this fairly recent paper out of Stanford, showed that these technical variants have, in the hands of a high volume center, have equivalent graft survival and reduces the waitlist mortality for those little babies who otherwise can't get a liver because there's no baby donors for them. The subsequent paper came out of this institution showing that we could take grafts, living-related grafts from adults, not just from the left lobe, but from the right lobe as well. And that has now become a standard technique as well in adult transplantation with equivalent results to the cadaver donors. So again, this is the number of liver transplants that we've done over the 25 years or so that since we came back to Colorado, and a steady growth, the latter part, mostly under the watch of Dr. Wax and Dr. Adams. So I'm going to move on to the last section, the Army lessons learned. And how did I get there? It's already talked about a little bit, but it's weird how all of these different phases are connected. One of the things we had and still have is a liver transplant selection committee. And on that committee is surgeons, hepatologists, nurses, anesthesiologists, and we also have a psychiatrist. And Dr. Robert House was our psychologist at the time. He would evaluate patients. Are they going to go back to alcohol? Are they going to go back to drug use? Are they crazy and not going to take their meds? And we needed that sort of input. So we sat together every Thursday morning to evaluate new patients. Well, 9/11 happened. And of course, there was this wave of sadness and patriotism across the country. And Dr. House, who was also the commander of the hospital unit in the back of the Fitzsimmons campus here, the 5502nd U.S. Army Hospital, leaned over one morning and said, "Would you be interested in being in the military? We need surgeons," because it was clear that we were going to war. And I thought for a moment and said, well, I guess, maybe, what's involved? And, one thing led to another. And, I don't know if it was my Boy Scout training, which is kind of paramilitary with troops and patrols and badges and ranks and so forth, or just patriotism or a midlife crisis. It's not quite clear. It was either that or a fast car or a mistress or something. But I decided maybe Army was a better choice. And so it happened. So I signed up and the recruiter said, well, you just go, you go to the base so that the active duty guy can go forward. Well, that was not true. So I put up here some of my influencers in this area. Dr. Kershaw, also a family practice doctor, was my scoutmaster of Troop 384. Bob House, who got me started on this journey. And then Bob Enzenauer, an ophthalmologist and brigadier general in the National Guard, who was an influencer towards the end of my career when there was an opportunity to say, okay, enough's enough. But he encouraged me to continue. So this is what happened. Rather than go to a base and the active duty guy would go forward, I went forward. Within a week of my basic training, I was in Iraq. And the first deployment was pretty sleepy. We didn't do much. It was out in Western Iraq. The big invasion was over. The insurgency had not started. The second rotation was exactly what he said I would do. I went to Tripler and replaced their pediatric surgeon, basically did what I do here, took care of kids. And then I went to Mosul and to Tikrit. I'll tell you a story about that. That was pretty busy. I went to Khost, which was really busy. That's on the eastern side of Afghanistan, right near Pakistan, and a very active combat area. Talat was pretty slow. Kandahar was pretty cool because we were supporting the Special Forces group and moved about from place to place as they were doing relatively clandestine operations. And then the final one was probably the most rewarding, which was to welcome the Afghan folks that had supported us, translators, cleaners, cooks, etc., that supported the troops in Afghanistan. And then as things were closing down, got out. And we were trying to get them relocated here in the States. So what did I learn? Well, it turns out that the majority of the injuries are listed here from this paper in 2008. The majority are from explosive injuries. And explosions are not something we see here in trauma very often. It results in multi-system injury rather than a single gunshot wound or a knifing or something, or more akin perhaps to blunt trauma, but also combined with penetrating trauma. The types of injuries that we saw are listed here. Head and neck injuries were increased in this war versus others. Thoracic and abdominal injuries were down, probably because a lot of this battle rattle, these protective flak vests and so on that we wear protect us. So most of the things that head and neck, there's a lot I can do for a head injury. They need to get evac to someplace where a brain surgeon can take care of them. But most of the injuries that we actually took care of were extremity injuries. And therefore the orthopedic surgeon was usually the busiest guy in the hospital. And often we help them with putting on external fixators or whatnot. This is Lieutenant Colonel Adelot. He was the head trauma surgeon in Tikrit. We had a number of mass casualties there. And he taught me Adelot's rules, which came in handy for a number of things. Get them naked, roll them over, chest x-ray. Why did he do that? Because when you have a whole bunch of people coming through your emergency room, one, you got to expose everything. Look everywhere, because with an explosion, there could be a tiny injury somewhere that you won't see unless you get them naked. Get all that battle rattle off. Roll them over. Look at the backside. They may look fine on the front, but they might have a serious wound on the back. And of course, that's what we do in trauma every day. And chest x-ray. This was done early so that no patient left the operating room or left the emergency room to go to the OR or to go to radiology without a chest x-ray, defining that they don't have some occult chest trauma that's going to get you in trouble when they get there. We also, I learned a lot about triage, and a couple of keys about triage is put your best man on it. It might seem counterintuitive to take your best surgeon and put them out in the ER or out in the the front door assessing patients, but they're the best and the most accurate about assessing patients to see how they're doing. They can then send them back to the OR, and you can do your exploratory lap or fix up their leg or whatnot. It's designed to not spend a lot of time on a severely injured patient that is moribund or not going to survive, but also to focus your attention on those that need the most immediate care. Then damage control surgery. Damage control is really a Navy term. It was developed to keep the capacity of the ship intact. And so the mantra of damage control in the Navy is, number one, put out the fires. Identify, extinguish, control any fire and minimize it or control it. Stop the flooding, stop to remove any water or close down those areas so that it won't flood the whole ship. And then evacuate, get everybody out, close all the hatches behind you. So how does that relate to trauma surgery? Well, stop the bleeding. I relate that to stop the bleeding is the same as stop the fires. Repair the arteries, ligate the veins. If it's a single organ, remove it. I mean, if it's a paired organ, remove it. It's a single organ, pack it or fix it. Stop the flooding, stop the contamination as quickly as possible. Staple things off, tie them off. Don't spend a lot of time with fancy anastomoses or repairing wounds of the bowel. And then wash out the contamination and drain. And finally, evacuate, don't linger. Get out of the abdomen or get the patient out of the OR as quickly as possible to prevent the lethal triad of hypothermia, acidosis, and coagulopathy. So along the way, I had the opportunity to see and take care of a number of children that were injured in war. A tragedy, obviously, but they often are the innocent bystanders of armed conflicts. So what did we learn? These are the lessons learned from a number of different papers, some of which I had something to do with. There's a joint trauma registry, joint theater trauma registry that is a robust cataloging of all patients that came through the medical system. The only time in general that we're able to take care of kids is if they meet the medical rules of engagement, being they have injuries to life, limb, or eyesight. But we also took into account the hearts and minds. If it was a kid that we thought we could help, that was important to the local community, we could intervene. It turns out that children represented about 6% of the admissions in both of these wars, but they were increased in the number of hospital days that they required because they were not able to get evac. Any military guy that was badly injured, they were out of there fairly quickly. They were more severely injured than other adult patients, whether military or locals. Most of them were male, and about half of them were under 7. Explosions, again, were the most common cause. Landmines, unfortunately, are common in war zones, as well as unidentified explosives, bomblets that are lying about. And kids are curious. They look at these things and they get themselves in trouble. Most common operations were simply wound debridements or skin grafting. As I mentioned, they required a longer length of stay and had a higher mortality than adults of the military or local type. Unfortunately, the military doesn't generally account for that. We have a lot of adult equipment, a lot of adult stuff to take care of the troops. We don't generally have a lot of pediatric endotracheal tubes, masks, IVs, blood pressure cuffs, etc. So many of these papers made that point that we need to plan for pediatric trauma even though we're not intending to do that, it happens. So I think I'm going to end here with this story. This is Sergeant Brendan. Sergeant Brendan was driving his MRAP, which is this giant mine-resistant vehicle, and it was struck by EFP, a explosive force projectile. So it passes this molten copper usually through armor, and it came right in the side door of his vehicle. He was severely injured. He came with traumatic amputations of both arms and both legs. He had an expanding hematoma in the left neck, excuse me. Which was a carotid injury, it turns out, requiring a saphenous vein graft. He had a fractured jaw and lost 8 teeth, numerous facial and other fractures and lacerations, a broken nose, tympanic membrane rupture, burns to his chest, neck, and anterior, and his face. And he survived. This was with Dr. Adelot, and he was the chief surgeon. We had 4 teams, 1 on each extremity. Controlled the hemorrhage, controlled the, fixed all the other injuries. He was with us, he came within an hour of his injury. He was with us for about 24 hours. He was evacuated that same day to Balad, which is near Baghdad, and then on to Landstuhl in Germany, and then Walter Reed, where he spent several months. And I hope this video will play. This is Brendan, who then went on to.
My name is Brendan Morocco, and I'm a double arm transplant. Well, I needed the transplant because the easiest way to put it is I got blown up in Iraq. That I was hit with an EFP, which is essentially a shaped charge of molten copper. So it's over 2,000 degrees because it was so hot. As it took me apart, it cauterized everything. So I wasn't bleeding. And the thing that took my arms and legs is what kept me alive, which is crazy.
Brendan was introduced to me.
So I don't want to play that whole video. It's pretty long, but he was the first serviceman to have a bilateral arm transplant. And at least from what I can tell from the internet, still has retained those arms. He's regained function slowly over time. It takes time for the nerves to grow back. They grow about 1 millimeter a day. So it takes, is it a day or a week? Week? Somebody from plastics could tell me. But no, I can't advance. Hold on. Sorry. Well, it did it again. I don't know what the deal is. There we go. Now it's up here, but not there.
By the Assistant Commandant of the Marine Corps.
That I do today. I do today without them. I do today without them.
This advance. Bottom. Oh. Sorry. Yeah, I have that, but it's not there.
Can you have the video up again?
No, video's done. I don't know. anyway, he survived. The message that I learned from him was keep plugging. Don't give up. Some of these guys have put their lives on the line and deserve, our best efforts. And that's true there. It's true here. Oh, there we go. So there he is, 10 years post-injury. One of the things that was impactful to me was I received a letter from his father in the aftermath of his injury. And I thought, boy, this guy, 4-limb amputation is going to be not a good outcome. But his dad was extremely thankful that we saved him, that he came back home, and then he was given this opportunity. Is this going to be a long-term success for him? I don't know, but he's got to do what he wanted to do most, which was to drive a car. And he has a nice fancy charger on his website. So finally, I just wanted to acknowledge a lot of the people that put me on the fence post. My partners in pediatric surgery, my partners in transplant, who supported me through all of these endeavors, other colleagues from other specialties, hepatology, anesthesia, critical care, and all the people that don't get any credit, the nurses and techs and advanced practice providers. And finally, my family, who allowed me to go on this crazy journey. Thank you very much.
So I think it's only appropriate that we end with another round of hearty applause for his service, not only to Children's Hospital, the department, but to our country. Thank you for your service.
Thank you. Thanks.
Thank you.
Any questions? I don't know if there's any time. No? Oh.
Dr. Carr, thank you so much for your presentation. And I'm just going to remind you of what you said at the beginning. When I called you and asked you to do this, you said you didn't have much to say. And I think you proved yourself wrong. Not only are you the expert, but you're also the jack of all trades. So you can be both.
Anyone have a question out there or a comment? All right, a third round of applause.
No, it's not. All right. Thanks.